Welcome to an overview of the health insurance marketplaces and the changes with the Affordable Care Act. This is Module 1, Training for Indiana Navigators. This is the Module 1 overview. After reviewing this module, you will be able to explain basic insurance concepts, including premiums and cost sharing, such as co-payments, co-insurance, and deductibles, and you will use this understanding to help consumers identify and understand the key costs on a health insurance plan description. You will understand the key concepts of the Affordable Care Act and how those concepts will impact consumers. These concepts will include health insurance marketplaces, health insurance plan changes, and subsidized coverage. You will be able to help consumers identify whether or not they may be eligible for coverage and cost assistance programs through state programs or on the federal marketplace, and you will be able to recognize consumer assistants that are authorized to help Hoosiers, and these consumer assistants will include Indiana Navigators. Terminology that will be used frequently in Module 1 and the modules to follow include federal poverty level. Federal poverty level is a measure that is released each year by the federal government, and it estimates the minimum amount an individual or family needs to make to cover basic living expenses. This measure reflects income and household size, and it changes annually. It may also be referred to as FPL. Affordable Care Act programs oftentimes refer to a percentage of federal poverty level. This is a percentage of the minimum amount an individual or family would need to make to cover their basic living expenses. Marketplace or Federal Marketplace is a federal website where consumers can shop for and purchase health coverage and apply for cost assistance. This may also be called an exchange. Large group plans, small group plans, and individual plans, or the large group market, small group market, or individual market, refers to the entities a plan or plans should be sold to. In Indiana, the large group market is for employers with 50 or more employees. The small group market is for employers with 2 to 50 employees, and the individual market is for individuals and their dependents. Health insurer, health insurance issuer, or health insurance carrier all refer to the insurance company that issues health insurance plans or policies. Grandfathered and non-grandfathered plan refers to whether a health plan is required to abide by ACA mandates. Grandfathered health plans were in existence prior to the ACA and have not had substantial changes. These plans do not have to comply with many of the ACA requirements. Non-grandfathered plans are required to comply with all applicable ACA requirements. The individual and employer mandates, or individual and employer shared responsibility requirements, refer to tax penalties that individuals or employers have to pay. The individual mandate applies to individuals who do not maintain minimum essential coverage, as defined by the federal government, and the employer mandate applies to employers with over 50 employees who do not offer their employees coverage after 2015. Health insurers use enrollee premiums to help cover the costs of medical care. All enrollees pay premiums into a fund. The insurer is responsible for managing this fund, for negotiating rates with providers, and for using the money in the fund to pay for enrollee medical care. Enrollee premiums are paid regardless of whether enrollees use health insurance or not, and these premiums are usually required to be paid to the health insurer on a monthly basis. In addition to enrollee-required monthly premiums, individuals may have to pay part of the cost of their care out of pocket when they visit a health care provider. These payments can come as a co-payment, which is a flat fee an individual would pay at the health care provider office before they see the provider, or as co-insurance, which would be a payment after the fact that they would receive for a percentage of the cost of coverage. Some health insurance plans also have deductibles, which is an amount the individual has to pay in full before health care coverage kicks in from the insurer. It's a set amount, and it's usually noted on the individual's summary of coverage. Once the deductible is met, the insurer may require only co-payments or may split the cost of care with the individual as co-insurance. Cost sharing is a common feature of different health insurance plans, and specific requirements vary between plans. To understand what any health plan may cost an individual for separate services, it's very important to review the summary of benefits and coverage. For health plans that are subject to ACA requirements, health insurers may only charge individuals a limited amount out of pocket for any calendar year of coverage. This is the maximum amount in copayments, coinsurance, or deductibles an individual could expect to pay over a plan year. For 2014, out-of-pocket maximum amounts are limited to $6,350 for an individual plan or $12,700 for a family plan. Insurers are not required to charge these amounts as out-of-pocket maximums, but the out-of-pocket maximums may be no more than these amounts for 2014. Health insurance plans, in terms of how they apply cost sharing, are all different. They may use any or all of the premiums, copayments, coinsurance, deductibles, and out-of-pocket maximums, and may have separate copayments, coinsurance, or deductibles for different services. Health insurance plans will have different rules about how these key terms are applied. For example, some plans may charge copayments for some services and coinsurance for other services. The health plan's cost-sharing policy can be found in their summary of benefits and coverage. This should be reviewed to help individuals understand what they will pay when they seek health coverage under their health insurance plan. In general, the Affordable Care Act targets uninsured individuals and adds consumer protections. Many uninsured individuals are lower income, and the Affordable Care Act adds subsidized coverage for individuals with lower incomes. It also adds a requirement that individuals may no longer be denied health insurance coverage if they have a pre-existing condition, and institutes penalties for individuals who do not have health insurance coverage and for large employers that do not offer health insurance coverage starting in 2015. Consumer protections include increased review of health insurer rate increases, requirements that insurance companies spend a certain percentage of collected premiums on direct medical care, and the requirement that all health insurance policies covered by the Affordable Care Act are guaranteed to be available to individuals and guaranteed to be renewable for individuals starting in 2014. The provisions of the Affordable Care Act impact both state Medicaid agencies and commercial insurance products. In addition, the Affordable Care Act gave states 3 options for setting up the new health insurance marketplace. States could select a state-based marketplace, a partnership marketplace, or a fully federal marketplace. Under a state-based marketplace, the federal government sets the guidelines for marketplace operations, and the states use those guidelines to set up and run the marketplace operations. Kentucky has a state-based marketplace. Under a partnership marketplace, the federal government is responsible for setting the guidelines and setting up and running the marketplace. However, the state takes on some marketplace responsibilities, including overseeing health insurance plans on the marketplace and managing consumer assistance. Illinois and Michigan are partnership marketplaces. The federal marketplace is solely run by the federal government. The federal government sets up the guidelines, sets up the marketplace, and runs the marketplace, and is responsible for implementing all marketplace provisions. Indiana and Ohio have federal marketplaces. This section of the presentation is going to cover the Affordable Care Act requirements for individuals and employers, including minimum essential coverage, the individual mandate, exemptions from the individual mandate, and the employer mandate. The Affordable Care Act requires that individuals maintain health coverage for themselves and their dependents. This health coverage is required to be minimum essential coverage to meet the requirement. Minimum essential coverage is a list of coverage types that is determined by the federal government. This coverage type list will evolve over time, and there are currently some types of coverage that are only recognized as minimum essential coverage for 2014. Types of coverage that are not currently recognized as minimum essential coverage can apply to the federal government for recognition as minimum essential coverage so that individuals can use this coverage to meet the individual mandate requirement. Individuals may receive exemptions for themselves and/or their dependents from the requirement to maintain minimum essential coverage. These exemptions can be received either through the exchange or through the IRS at tax filing. Individuals that do not maintain minimum essential coverage or receive an exemption for themselves and their dependents may be subject to the individual mandate penalty or the shared responsibility payment requirement. This is a tax penalty which an individual may owe when they file their taxes, and it varies by year and by income. Individuals must pay the greater of either the dollar penalty or the percent penalty up to the maximum penalty amount, which is the national average cost for a low-cost coverage plan that would cover the applicable individuals and their dependents. In 2014, the penalty for an adult is $95 or 1% of household income, and the maximum dollar penalty for a family would be $285. If the percent of income penalty was greater than $285 or the applicable dollar penalty, the individual or family would pay the percent of income penalty. Individual mandate penalties are owed for each month that an individual is not covered. The amounts displayed here are the annual amounts, and for every month an individual is not covered, the individual would owe 1/12 of either the dollar amount penalty or the percent of income penalty, whichever one applied to the individual. To avoid paying the individual mandate penalty or the individual shared responsibility payment requirement, individuals have to maintain minimum essential coverage or receive an exemption from the requirement to maintain minimum essential coverage. The list of minimum essential coverage includes government-sponsored health insurance, such as the Medicare program, most Medicaid programs, Children's Health Insurance Program, veterans programs, including TRICARE and CHAMP VA, and coverage for Peace Corps volunteers. Employer-sponsored health insurance also counts as minimum essential coverage, as does coverage available in the individual market. Individuals that are covered on grandfather plans, even though these plans are not required to meet ACA requirements, will meet the individual mandate requirement to maintain minimum essential coverage. Self-funded student health coverage is considered minimum essential coverage in 2014. However, most student health plans are not considered self-funded student health coverage, so students will need to ask their health plans if they meet the minimum essential coverage requirements. Refugee medical assistance is considered minimum essential coverage, as are Medicare Advantage plans or Medicare Part C, and limited to 2014, state high-risk pool coverage is considered minimum essential coverage. However, Indiana's state high-risk pool, ACA, is phasing out in 2014. Additional coverage may also be specified as minimum essential coverage, and this list may be updated as the federal government identifies new types of minimum essential coverage. Some individuals may have health coverage that is not considered to be minimum essential coverage. For example, certain Medicaid programs, such as Medicaid programs that cover only family planning services or are limited to pregnancy-only services or emergency services, will not count as minimum essential coverage. In addition, limited scope benefits or coverage offered on a separate policy from primary health coverage will not be considered minimum essential coverage. This would include accidental death and dismemberment coverage, automobile liability insurance, disability insurance, workers' compensation, long-term care benefits, vision benefits, or separate policies to cover a specific health condition, such as cancer-only policies. Individuals with these coverage types will either need to maintain coverage that is minimum essential coverage, obtain an exemption, or pay the individual mandate tax penalty. One of the exemption types that individuals can obtain from the requirement to maintain minimum essential coverage is an exemption for unaffordable coverage. Individuals can obtain an affordability exemption if the cost of coverage is more than 8% of household income. In addition, individuals may be eligible for subsidized coverage under the premium tax credit program if the cost of coverage is more than 9.5% of income. These eligibility for affordability exemptions verify based on what type of health insurance the individual is eligible for. For employer-sponsored insurance, the individual-only premium has to cost more than 8% of income for the employee to get an exemption. The employee's dependents may receive an exemption from the requirement to maintain minimum essential coverage if family coverage costs more than 8% of income. However, to be eligible for subsidized coverage under the Insurance Affordability Program, the employee-only coverage must cost more than 9.5% of income. If the employee coverage does not cost more than 9.5% of income, even if the coverage with dependents does cost more than 9.5% of income, neither the employee nor their dependents would be eligible for subsidized coverage under a premium tax credit. Individuals that would like to apply for an exemption may send an exemption application to the Federal Marketplace or the Internal Revenue Service. Individuals with questions about affordability exemptions or other types of exemptions should contact the Federal Marketplace call center at 1-800-318-2596. In addition to the exemption for unaffordable coverage where coverage costs more than 8% of household income, there are exemptions available for religious conscience, for individuals who have a religious objection to health insurance, for having household income below the filing limit, for being a member of a federally recognized tribe, for not being lawfully present in the United States, for various forms of hardship, for being a member of a healthcare sharing ministry, for being incarcerated, and for a short coverage gap lasting not more than 3 months. The Affordable Care Act contains an employer mandate or employer shared responsibility provision that impacts large employers. Initially, this employer shared responsibility provision would have begun in 2014. The provision has been delayed until 2015, and beginning in 2015, employers with more than 50 full-time equivalent employees will be subject to penalties if at least one full-time equivalent employee receives a premium tax credit. Employees can only receive a premium tax credit if they have income between 100% and 400% of the federal poverty level, and if employer coverage is not available, or if employer coverage does not provide minimum value by paying at least 60% of the health care costs, or costs more than 9.5% of income. When these conditions are met and employees receive premium tax credits, employers with over 50 full-time employees will owe employer mandate penalties beginning in 2015. Starting in 2015, large employers who have employees that receive premium tax credits will be subject to a penalty. This penalty varies based on whether the employer offers coverage to at least 95 of its employees or not. For employers that offer coverage to at least 95% of employees, they will pay $3,000 for every employee that receives a premium tax credit, or 1/12 of this amount for every month an employee receives a premium tax credit. If $3,000 for every employee receiving a premium tax credit is greater than the amount an employer would pay if they did not offer coverage, the employer who offers coverage to at least 95% of their employees will pay the lesser amount. For employers who do not offer coverage to at least 95% of their employees, they will pay $2,000 for every full-time and full-time equivalent employee, excluding the first 30 employees. These penalties will initiate for the coverage year 2015. This next section will cover the insurance market changes of the Affordable Care Act, including medical loss ratio, rating rules, essential health benefits, and actuarial value. The Affordable Care Act includes numerous changes to health insurance markets. One of the main changes is that health insurers are now required to have a minimum medical loss ratio, or a minimum amount of premiums that they spend towards the cost of medical care for enrollees. Health insurers with low medical loss ratios, or who spend a lower percentage of their premiums towards the health costs of enrollees, will be required to issue refunds to enrollees. This limits the amount of premiums that individuals pay that go towards health insurance administrative cost and profit. Unreasonable rate review means that while states will review all premium rate increases, there is an additional layer of rate review for any premium increases over 10%, and the federal marketplace will look at these premium rate increases and make a recommendation to the state. Rating rules requires that insurers may no longer rate based on health history or gender, and premiums may now be based only on age, location, and smoking status. Individuals with pre-existing conditions may not be excluded from coverage. Guaranteed availability and guaranteed renewability mean that health insurers may not refuse to issue a policy to an individual or refuse to renew a policy for an individual, regardless of any pre-existing conditions or health conditions that developed over the course of the policy year. Additionally, since 2010, the Affordable Care Act has required that insurers offer the option for members to include adult dependents on their health plans up to dependent age 26. The ACA also expands coverage for preventive services, and many preventive services initiating in 2014 are required to be covered without applying enrollee cost sharing. For individual and small group plans, the Affordable Care Act requires that these plans cover the essential health benefits, which is a list of benefits that insurers must offer. Both lifetime and annual maximum coverage limits are also eliminated, and insurers may no longer put dollar limits on coverage that are part of the essential health benefits. Two additional changes on the health insurance marketplace initiated by the Affordable Care Act are actuarial value and minimum value. Actuarial value is a number that refers to the percentage of plan costs an insurer expects to pay versus what it expects the enrollee to pay in cost sharing. In general, plans with a higher actuarial value will have higher premiums and lower cost sharing. For example, a health insurance plan that expects to cover 90% of all enrollee medical costs will charge higher premiums than a health insurance plan that expects to cover 60% of all enrollee medical costs. All individual and small group market plans that have non-grandfathered status must have a standard actuarial value that is displayed to the consumer. Minimum value refers to the actuarial value that employer-sponsored insurance plans must have to meet the minimum value requirements. Employer-sponsored insurance must offer plans with an actuarial value of at least 60%. If employer-sponsored insurance does not offer health plans with this minimum value, employees may be eligible for insurance affordability programs, and the employer may be subject to the fines as part of the employer mandate or employer shared responsibility provisions. Medical loss ratio, as previously noted, refers to the percent of premiums collected by an insurance company that is spent on medical services for enrollees. The new requirement of the Affordable Care Act, which has already been implemented, requires that health insurance in different market segments meet certain medical loss ratio requirements. For example, the large group market health insurers must have a medical loss ratio of at least 85%. If the medical loss ratio is not 85%, or if the insurer does not spend 85% of collected premiums on enrollee medical care, the health insurer will be required to issue a refund to the large group employer. Small groups and individual markets must meet the 80% medical loss ratio requirement. This means that small group plans and individual plans have to spend at least 80% of collected premiums on medical costs. When this requirement is not met and less than 80% of premiums are spent on medical costs, the insurers must issue a refund to the small group or to the individual that purchased the plan. These refunds will be issued by September 1st of every year. Non-grandfathered health plans, or health plans that are subject to the Affordable Care Act rating requirements, are limited in how they can develop a premium rate for what to charge an individual for health coverage. Health insurance plans may only use 3 factors: age, tobacco use, and geographic location to develop a premium rate for any individual. Age is limited to a 3-to-1 ratio, which means that an individual who is age 21 may pay 1/3 the premium of an individual who is age 64. However, that individual age 64 is guaranteed their premium will never be more than 3 times as much as any other covered individual. Tobacco use is limited to a 1-to-1.5 ratio, which means that health insurance issuers may charge up to 1.5 times as much premium for an individual who smokes compared to an individual who doesn't smoke. Health costs vary by geographic area, and premiums may change depending on where individuals live. Health insurance plan premiums cannot consider an individual's gender or an individual's health status. Insurers may not exclude individuals or health conditions from their coverage based on pre-existing conditions or any conditions that develop while being covered on the policy. Beginning in 2014, health insurers in the individual and small group market will be required to offer the essential health benefits. The essential health benefits are sets of benefits that are offered in the 10 essential health benefit categories. The first category is ambulatory patient services or doctor's office visits and outpatient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse disorder services, prescription drugs, rehabilitative and habilitative services, laboratory services, preventive and wellness services, and pediatric services with oral, dental, and vision care must all be covered by individual and small group plans beginning in 2014. The 10 categories of essential health benefits do not identify what specific benefits will be covered under any category. To identify the specific benefits covered under, for example, ambulatory patient services, each state looked to a benchmark plan and categorized the benefits in that benchmark plan into the 10 essential health benefits categories. This set the baseline for the benefits that must be covered in the individual and small group market for 2014 and 2015. Indiana's Essential Health Benefit Benchmark Plan is the Anthem Blue Access PPO plan, and the link to the benefits in this plan is displayed on this slide. These benefits in the 10 EHB categories are subject to change in 2016, but they apply to the Indiana market for 2014 and 2015. All health plans that are subject to the essential health benefit requirements, which means all non-grandfathered plans in the individual and small group markets, have to offer plans at standard actuarial value levels. As previously mentioned, actuarial value means the average percent of medical cost the insurer expects to pay for all covered enrollees. For example, all plans in the individual and small group market have to offer plans in a certain metal level. So a bronze level plan would have a 60% actuarial value, or the insurer would expect over all enrollees that it would cover 60% of total medical costs, and that enrollee cost sharing would cover the remaining 40% of medical costs. Under a platinum plan, the insurer would expect to cover 90% of all medical costs, and the enrollees would expect to cover 10% of all medical costs through cost sharing. Plans with higher actuarial values or higher metal levels in general will have higher premium costs and lower cost sharing. For any individual selecting an actuarial value level plan, or for example, a silver plan, the percentage of costs covered by the individual may vary. Actuarial value represents the average over all individuals enrolled in the plans, and any single individual may pay more or less in terms of a percentage of medical costs than is displayed as on the actuarial value level. However, actuarial value is a good indicator of how rich the benefits in the plan are and how much an enrollee would expect to pay in cost sharing versus premiums. This next section will cover the affordable coverage provisions of the Affordable Care Act, including tax credits, cost sharing reductions, and the optional Medicaid expansion program. The Affordable Care Act offers premium tax credits for individuals who qualify. Premium tax credits are a form of subsidized coverage which help enrollees afford health insurance premiums. To receive a premium tax credit, individuals must be a citizen, national, or legal resident of the United States, an Indiana resident, and non-incarcerated. Additionally, individuals receiving premium tax credits must have household income between 100% and 400% of the federal poverty level, and may not be eligible for other minimum essential coverage, including Medicaid or employer-sponsored insurance, or have access to other minimum essential coverage, but that coverage is unaffordable and costs more than 9.5% of household income, or the coverage does not provide minimum value by covering at least 60% of the expected medical costs. After the initial year of eligibility, individuals must file their taxes to continue to be eligible for premium tax credits. A second insurance affordability program or subsidized coverage option for individuals who qualify is a cost-sharing reduction. To receive a cost-sharing reduction, individuals have to meet all of the requirements for the premium tax credit that were displayed on the previous slide, and have household income between 100% and 250% of the federal poverty level. In addition, individuals must enroll in a silver plan or a 70% actuarial plan on the federal marketplace to be eligible for cost-sharing reductions. Cost-sharing reductions reduce the amount of out-of-pocket costs an individual could expect to pay for medical care. Like premium tax credits, individuals are not eligible for cost-sharing reductions in years after their initial enrollment year if they fail to file their taxes. Premium tax credits are based on a percent of income contribution that is indexed to an individual's federal poverty level. For example, an individual from 100% to 133% of the federal poverty level would expect to pay 2% of their income towards the cost of a plan. The income contribution amount is indexed towards the cost of the second lowest cost silver plan offered on the marketplace, and the estimated annual contribution of $230 to $306 for an individual in this income range will vary depending upon the plan they select. Individuals up to a certain income percentage are also eligible for the cost-sharing reductions. So an individual at 133% to 150% of federal poverty level would pay 3 to 4% of their income for their health plan and then would benefit from a cost-sharing reduction that would increase the actuarial value of their health plan to 94% from 70%. Individuals only receive the cost-sharing reduction if they enroll in a silver plan on the marketplace. The Affordable Care Act also includes an optional Medicaid expansion that states may elect. Indiana has currently not expanded Medicaid. However, the state is working with the United States Department of Health and Human Services on the future of Indiana's Healthy Indiana Plan. The governor has made it clear that any discussion of a health coverage expansion in Indiana must begin with HIP, and the program's goal overall is to focus on long-term sustainability for the Medicaid program. Individuals can seek coverage through current Medicaid programs, through the federal marketplace, and through coverage offered outside of the federal marketplace. This next section will address health insurance marketplaces under the Affordable Care Act. Beginning in 2014, there will be 2 ways for individuals to purchase health insurance in Indiana. Individuals can still purchase health insurance through the commercial insurance market as they do today. The commercial insurance market is overseen by the Indiana Department of Insurance, and individuals, small groups, and large groups can seek coverage options here. The federal marketplace begins to offer coverage in January of 2014. This marketplace is administered by the Federal Department of Health and Human Services, and it serves individuals and small groups. Individuals will use the federal marketplace, and small groups will use the Small Business Health Options Program, or SHOP. The federal marketplace is a website for individuals and small businesses to compare and purchase health insurance. It also will assess individuals' eligibility for Medicaid. If the individual is eligible for Medicaid, the federal marketplace will send the individual's application to the state Medicaid agency. It will assess eligibility for premium tax credits and cost-sharing reductions, and will also complete individual mandate exemptions. The federal marketplace will manage eligibility appeals and facilitate enrollment in qualified health plans. It will ensure that appropriate premium tax credit and cost-sharing reduction payments are sent to the health insurance plans, and it will collect and publish quality data on the health plans. In addition, it operates a consumer assistance call center, and starting in 2015, it will collect premiums for small businesses. The Small Business Health Options Program is a marketplace for eligible employers. In 2014 to 2015, in Indiana, the SHOP will be available for employers that have less than 50 full-time equivalent employees. For 2016 and after, the SHOP will be available for employers with less than 100 full-time equivalent employees. Employers that are using the SHOP may use agents or brokers as they do today, or can enroll in the SHOP independently. Qualifying employers can receive a tax credit if they have less than 25 employees. Starting in 2015, the SHOP will offer the opportunity for employers to choose either a specific plan or a selection of plans to offer their employees. Employers who choose a selection of plans will then choose a reference plan to help them set the contribution level for employees. Enrollment in the federal marketplace for individuals is limited to initial and annual open enrollment periods. The initial enrollment period for 2013 to 2014 is the 1st of October 2013 to the 31st of March 2014. During this period, individuals must enroll in coverage or they may not have access to coverage options after the period closes. Each year, the annual open enrollment period is from October 15th to December 7th for individuals to enroll or re-enroll in marketplace coverage. Individuals will not be able to access coverage options on the federal marketplace outside of these periods unless they experience a special enrollment event. Individuals may enroll in coverage outside of the enrollment periods if they have lost minimum essential coverage, had a change in family size or a change in location, or for other reasons. Health insurance plans that are offering coverage off of the marketplace may elect to conform to the open enrollment period requirements. This means that individuals who do not purchase coverage either on or off the federal marketplace during the enrollment periods may not be able to access coverage at other points in the year unless they experience a special enrollment event. SHOP enrollment does not conform to the individual open enrollment periods, and small businesses may enroll with the SHOP at any time during the year. As an Indiana navigator, you may interact with the federal marketplace by completing an application for the federal marketplace coverage. Indiana navigators are expected to be able to help individuals complete applications for coverage on the federal marketplace. You may also help individuals select a plan on the federal marketplace and provide general information on the available plans. General information means you can detail what types of cost sharing or benefits the plan may cover. However, you may not offer individuals advice on what plan to select. You may also direct consumer inquiries to the marketplace via the federal website at www.healthcare.gov or to the federal call center at 1-800-318-2596. Types of inquiries that may be directed to the marketplace are federal-specific inquiries, such as how to get an exemption from the individual mandate. This section will give a brief overview of the Affordable Care Act's Modified Adjusted Gross Income requirements. Modified Adjusted Gross Income is also referred to as MAGI and is a way to determine eligibility for health insurance affordability programs. This methodology is used for some Indiana Medicaid programs and for all federal marketplace programs that include premium tax credits and cost-sharing reductions. What MAGI is a way to count household income. It takes the adjusted gross income as reported on a federal tax return and adds back in amounts, including amounts that were excluded as foreign earned income, any tax-exempt interest, and tax-exempt Title II Social Security benefits. This is the income that is used to calculate an individual's federal poverty level and to determine if they are eligible for premium tax credits, cost-sharing reductions, or some Medicaid programs. Individuals who have not filed taxes or whose information has changed substantially since tax filing may use current income and may be able to prove income through a collection of pay stubs or bank account statements. This next section will cover changes the Affordable Care Act made to the Medicaid program. Medicaid is a program that is jointly funded by the state and federal government, and it provides free or low-cost health care to low-income children, parents and caretakers, pregnant women, aged, blind, and disabled individuals. There are many different programs, and who is eligible for these programs and what criteria they must meet varies by group. Some of the changes the Affordable Care Act made to Medicaid include a new way of counting income, the modified adjusted gross income methodology that was previously mentioned, some new eligibility groups, new categories for Medicaid, and new presumptive eligibility procedures. Modified Adjusted Gross Income, or MAGI, is a standardized income counting method that is used across all states. It's used both in Medicaid and the federal marketplace programs to determine eligibility for tax credits and cost-sharing reductions. In Medicaid, it changes how people are counted in the household, how income is counted, and how assets are considered. For new applicants, the MAGI change will impact adults, parents and caretaker relatives, children, and pregnant women. For individuals that are approved for Medicaid prior to December 31st, 2013, when they are redetermined for Medicaid or a change is reported, they will be subject to the new way of counting income that is provided by MAGI. Certain Medicaid groups are exempt from MAGI calculation. These groups include the aged, blind, and disabled groups. The Affordable Care Act created some new eligibility groups for Medicaid. Beginning in 2014, Medicaid must cover former foster care children up to age 26. These are foster care children who were covered by Medicaid and residents of Indiana when they aged out of the foster care system. There are no income limits for this group, and any former foster care child that meets these requirements will be eligible for Medicaid up to age 26. The Affordable Care Act also requires that children aged 6 to 18 be covered up to 133% of the federal poverty level. This is not a change for Indiana, as the state already covers this eligibility group. The Affordable Care Act also impacts Medicaid categories. With the implementation of MAGI, some eligibility categories or aid categories will change. This is a name change or an operational change only, and some categories are combined or will have new names starting in 2014. These category changes do not impact the benefits that are offered under any category. One of the major Affordable Care Act changes to the Medicaid program is the presumptive eligibility requirements. Presumptive eligibility is short-term coverage that is offered while a Medicaid application is pending, and it's offered for limited low-income populations. Currently, the state operates a presumptive eligibility program for pregnant women. However, Starting in 2014, because of the ACA, hospitals can be authorized by the state to operate a presumptive eligibility program. These hospitals that are authorized by the state to operate these programs will be referred to as qualified providers, or QPs. Qualified provider hospitals will be able to determine presumptive eligibility for children who are under 19, for low-income parents and caretakers, for the family planning eligibility program, and for former foster care children up to age 26. This next section will cover the Affordable Care Act consumer assistance. Indiana residents have many different types of consumer assistance that may provide assistance with enrollment in Marketplace or Medicaid coverage. These consumer assistants include Indiana navigators, who must complete the Indiana Navigator certification process, application organizations that must register with the state, authorized representatives that consumers designate, and health insurance agents and brokers that are currently available to help consumers enroll in health coverage. Other consumer assistant titles consumers may see include a federal navigator or a certified application counselor. Certain individuals must be certified as Indiana navigators. Individuals who work directly with consumers to complete health coverage applications, either for the federal marketplace or for Indiana health coverage programs through Medicaid, must be Indiana navigators. Individuals that are federally funded, federally selected navigators, federally designated certified application counselors, who work at Medicaid enrollment centers as staff or volunteers, or staff and volunteers of other organizations, may be subject to the Indiana Navigator certification requirements. Certain organizations are required to register as application organizations under the Indiana Navigator program. Organizations with employees or volunteers that assist consumers with applications on the federal marketplace, either for qualified health plans or for insurance affordability programs, including premium tax credits and cost-sharing reductions, are required to register as application organizations. In addition, organizations that use employees or volunteers to assist consumers with Indiana health coverage programs, such as Medicaid, the Healthy Indiana Plan, or CHIP, are also required to register as Indiana application organizations under the Indiana Navigator program. This concludes Module 1. Having completed this module, you should feel prepared to explain basic insurance concepts, including premiums, cost sharing, such as deductibles, copayments, and coinsurance, and out-of-pocket maximums. You should be able to help a consumer identify and understand the key costs on a health insurance plan description, including cost-sharing features and premiums. You should understand the key concepts of the Affordable Care Act and how those concepts will impact consumers. These concepts include health insurance marketplaces, health insurance market changes, and subsidized coverage. You should be able to help a consumer identify whether or not he or she may be eligible for coverage and cost assistance programs through either state programs or on the federal marketplace. This would include state Medicaid programs, premium tax credits, and cost-sharing reductions. You should also recognize the consumer assistance that are authorized to help Hoosiers and what sort of requirements apply to these consumer assistance.